Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. And in this episode, we're going to talk about something that is incredibly important to having a quality life, and that is having healthy, functional joints. We don't think about joints until they're not working properly. And just think about the complexity of joints, like the shoulder. Have you ever thought about how the shoulder moves? It can go in so many different directions, up and down and around. You can do the wave, you can do all kinds of things. The knee is a little bit simpler. It just kind of goes back and forth. But whoa, do we ever need to have functional knees? And the hip is pretty complex, but it doesn't go in every single direction. The way that, you can have your wrist go. Think about how that is complex. And the joints of the fingers, it's really amazing the way joints work. Well, there's a big event that happens in the life of every woman that has a huge impact on joint health and rarely gets discussed. And that is the loss of vital estrogen in the form of estradiol, the estrogen made by the ovaries. It turns out that before menopause, men have far more trouble with their joints, maybe because of they play sports and so on. But after menopause, women suffer from joint problems far more than do men. In fact, you probably didn't know this, because once upon a time, I didn't know this either, that who has more joint replacements? It turns out it's women, post-menopausal women. It's a huge problem. So is it just a coincidence that women, when they get older, have degrading, degenerative joints at a higher rate than men? No, it's not just by chance, and it's not about age. It's about loss of this vital life hormone. So if we think about what estrogen does, and I'm saying estrogen, but I'm talking about estradiol. I just know that most people don't use the word estradiol, but that's the type of estrogen I'm referring to. Well, estradiol, has receptors in every structure, every organ system of the body, and that includes the joints. So when we don't have enough estradiol, we do have trouble with the joints. Now, there's another interesting thing that can happen that is not talked about very much, and that is in younger women, if they are on certain types of hormonal contraceptives, they may not have normal amounts of estrogen. In fact, there are some types of contraceptives that may actually get rid of estrogen altogether, like progestin types of hormonal contraceptives that just have progesterone mimics, okay? No estrogen in them at all. And they are used, and they actually will have those women using them will have very low levels of estrogen because it stops ovulation, and then you don't have more than just a minimal amount of estrogen produced. And women who have Depo-Provera shots, those are the shots of the fake long-acting medroxyprogesterone acetate, their estradiol level goes way, way low. We know that in the first year or two, when you have a progestin IUD, such as the Mirena IUD, you may have lack of ovulation and reduced estrogen production as well. And then, of course, there are women who are treated with drugs that take away their hormones altogether, like for conditions like endometriosis, where they get drugs like Lupron that shut down ovarian hormone production. Well, women who have been using these types of products during their reproductive years may also have advanced or accelerated aging of their joints. And I see this in my practice all the time, like a woman who's maybe been on birth control pills with very low amounts of estrogen, and it may not be enough to develop the joints in a proper optimal way, because women may go on these drugs, these hormonal contraceptives with very, very low amounts of estrogen in them when they're only like 15, 16, or even younger. And then they're on them for sometimes like 15, 20 years. And then in their mid-30s, when they've been on them now for 20 years, they go to a Zumba class, or they go out and take up some other activity, and they use their shoulders, and they're doing nothing. They're just like moving their shoulder up, and they have a tear in their shoulder, or they're doing some other activity and they get a labrum tear, like for example in their hip. And it's like, what the heck is going on here? It's because their joints are like an accelerated aging status because they never optimally developed in the first place. But even if you have optimal joints all your life, when you go through menopause and you lose your ovarian production of estradiol, you're going to have changes. In fact, about 50% of women, when they are transitioning into the early years of menopause, will have symptomatic joint pains. So like half of women will have joint pains early on. And we're not talking about late stage when they're like in their 70s, when of course it's much higher. But even in the early stages of menopause, half of women are already having symptoms of joint pain. So this is really a big deal. We cannot live a quality life if we do not have optimally functioning joints. Now, another thing that's often not considered about when the people are talking about joints is that what is a joint anyway? You're connecting bones. So you have, like, for example, if you think about your elbow, you have the humerus up here, the radius over here. So you have bones that are joining, right? And you want to be able to move. So you have an elbow joint, okay? Well, joints everywhere involve the two bones or more coming together and then having ability to move things. So bone health is actually part of joint health. And a lot of people don't think about that when women, everyone knows, this is like universal, everyone knows, that osteoporosis occurs far more in women. 80% of osteoporotic fractures are in women. So women lose bone, and they lose bone years before the official date of menopause, defined as 12 consecutive months without any spontaneous bleeding. Years before that, hormones are changing, they're declining, and bone loss is occurring, as are other problems in the joint, as I'll discuss. And when you don't have quality bone, you can't have a healthy joint. So it's not talked about enough. People know about collagen, cartilage, tendons, but they don't think about bone as part of a joint. If you have a bone that comes to another bone and then there's a joint so that they can move, well, if the bone becomes poor in health and it becomes more osteoporotic, the covering of that bone, so when you have a joint, you have to have a cover so it's not, and you probably heard this expression, bone on bone. You don't want bone on bone. You have a cartilage covering. It's kind of like, a little slick kind of a cover so that it can be soft and smooth, okay, as opposed to bone on bone. Well, if you start losing bone, the covering is not going to fit snugly. So if you have bone that changes, then the covering, like the meniscus in a knee, okay, think about that. The meniscus won't fit properly, or in, say, a hip, we call that covering there of the cartilage the labrum. It doesn't fit well. It starts to fray off. They say it tore. It didn't really tear. It became frayed and it separated from the bone. And once it separates, we do not have a good way of putting it back when it's due to loss of estrogen and degradation of the joint. It's not like a trauma. It's just literally falling apart. And that's why those surgeries don't work. You can't like staple it back together when it starts coming off, like the labrum, the covering, the cartilage covering, like in the hip. You can't put it back. So then you're going to have, over time, loss of that vital cartilage covering, and that's how you end up bone on bone, and then you end up with a hip replacement, which isn't the end of the world. Thank goodness now we do have the ability to have joint replacements, but what's the best? To have your own joints working well all your life. So now you know the health of bone matters, and then you need to have optimal bone. Well, what about the other parts of a joint? I mentioned the covering, the meniscus, the labrum that covers the bone. Okay, so you don't have bone on bone. Well, that is vital in function, and it will depend on having adequate estradiol for having adequate structure. So you can't have proper collagen production, elastin production that keeps things soft and flexible. It requires estradiol, and this is not widely known, but now you know it. To have the building blocks of a joint, the elastin, the proper fibrous tissue, the collagen requires adequate estradiol production and levels. When you're young, you have these connective tissue products and like in a joint, and they flex and bend. But guess what happens when you go through menopause? Because estradiol is essential for the flexibility of these structures so that things can bend and be flexible so that you can move properly. They do not continue to have that flexibility. Instead of flexing and bending, they rip and tear. That's why you can do things that you did like 20 years ago, but now you're 55. You rip and tear. A lot of times the tissue actually is like, have you ever seen like fabric that's old and it literally is starting to fall apart? That's what happens to the connective tissue. That's what happens to fascia. That's why women get, vaginal prolapse. Well, the connective tissue that's so vital for joint function actually starts to degrade and it doesn't repair properly. The repair mechanisms, the growth factors for repairing joints. Remember, the tissue dies, the cells die, they need to be replaced with new cells from your stem cell pool. But the problem is, if you don't have adequate estradiol on board, you don't properly pull the stem cells to become new cells, and you don't properly do repair mechanisms. So the joints start to degrade and they do not get properly repaired either. And then when they do make new tissues, they're not healthy tissues because you don't have adequate estrogen to create proper health. And every tissue in the body to be alive needs nutrients and oxygen. And as we get older, through the menopause, our vascular system becomes more compromised. So we don't have proper nutrients and blood flow coming into the joints as well. And so you have this degradation of the joints. And of course, that leads to disability and pain and ultimately surgeries. And by the way, there's plenty of data showing that if you do surgery, like when they say, I'm going to just smooth out the cartilage, they're actually taking off the cartilage. It's not like frosting on a cake. You can like smooth it around. It's not like frosting on a cake. It's like firm, okay? So they're actually removing the pieces of the cartilage that have separated from the bone. They're just removing it because it's like flapping in the breeze, but they're not like smoothing it around because it's not something you can smooth around. So over time, if you have those surgeries, what have they shown? If you're over 50, you're actually accelerating your pathway into needing a joint replacement. Doing joint surgery because the joint, now I'm not talking about if you were in an accident, I'm talking about just living your life and the joint is literally kind of degrading and falling apart. And that's how it usually is, okay? Or if you have an injury, it's like a really small injury. You shouldn't have had, your joint fall apart like that. So the tissues of the joint are not good, okay? So if you try to have surgery, there's a very high medical probability, nothing guaranteed, a high medical probability that you're going to increase your risk of needing a joint replacement because you're taking away whatever little cartilage may be acting as a protectant, and you get closer to bone on bone. So, and then it's the pain. I mean, you just can't live with the pain when you have bone on bone. So surgery is not a good option, and I'm short of, trying to repair, not a joint replacement. Joint replacements can be very beneficial when you have to have them, but that's what we're trying to avoid. And you don't want joint replacements for every joint in your body. That is not really viable. And there are women that have basically pain in all their joints. Now, most of the joint pain we call osteoarthritis. Now, you do have to rule out other causes of joint pain because another condition that's really common is in menopausal women in particular is rheumatoid arthritis. So there are ways through blood tests, we're not going to go into that now, where you can help to distinguish between osteoarthritis and rheumatoid arthritis. So I'm not going to go into more than that, but we're talking about the age-related degradation or joint degeneration that is known as osteoarthritis. And that is really, like I said, prominent. Over 50% of women, as they're transitioning into menopause, will have joint pain. Women have more joint replacements. So, estrogen is critical for maintaining joint health. And not just I mentioned like the cartilage, the bone, but the liquid lubrication, the hyaluronic acid that's in joints, so that keeps the moisture, the lubrication, all depends as well on having adequate estrogen to have that moisture. So, of course, I'm going to say that going on hormones really matters. Now, here's like some really clear-cut, talk about clear-cut. Let's look at this. A 2023, it was a small study, but in 2023, there was a study that looked at shoulder capsulitis, also known as frozen shoulder. By the way, the vast majority, way over 90%, close to 100% of cases of frozen shoulder, where you have really limited movement, you can't go straight up, very limited movement, and a lot of pain in the shoulder, almost all of it occurs in early stage menopausal women. So that's also not a shocker coincidence. It's because of loss of estrogen. So there was a study I just started mentioning in 2023 that showed that women who were on hormone therapy had a 99% chance of not having frozen shoulder. So 99% reduction in frozen shoulder for women on hormone therapy. Now, it didn't go into great detail. I think, of course, dose always matters. But what a telling tale that is, how protective hormones are to prevent frozen shoulder. So to me, that's like, whoa, that's screaming, you need hormones, right? And we know that, as I said, the progression of degenerative joint disease accelerates so dramatically as women lose their hormones. So we can give hormones, but what else? Because as I say over and over, even when we do our best, it's not the same as having a new set of 21-year-old perfectly functioning ovaries. So we can also access supplements. There are some really beneficial supplements that reduce inflammation. Some may even help promote joint rejuvenation. So that's pretty darn good. So the most common one that's used would be glucosamine combined often with chondroitin. Now, there's some data suggesting that glucosamine alone is really the most beneficial part of the combo, but there's no harm in giving the combination. You have to be careful if you're using chondroitin that the individual doesn't have, or it could be you, doesn't have an allergy to shellfish, okay? That's important to know for the chondroitin part. And if you use the glucosamine, please get glucosamine sulfate, not hydrochloric, okay? Glucosamine sulfate. Now, this may work in a variety of ways. We think it actually helps the joint to be more lubricated, may even help to improve elastin, and helps to produce glycans. So glycans are like the mucus polysaccharides that help to create the lining. It's like to make things smooth. Okay, so you need to have those glycans. There's different types of glycans that are produced, and glucosamine seems to help the joint to actually rejuvenate to a certain degree by producing more of these glycans and moisture within the lubrication liquid within the joint itself, and may help to actually create more cartilage. So glucosamine plus minus chondroitin is a good choice. Now, what about for pain? I mentioned that at least half of women as they go through menopause have pain. Pain always means inflammation, okay? Always. You would not have pain if you don't have inflammation. That's how it works. So one of my favorites for reducing inflammation is boswellia, also known as Indian frankincense. And there's some really good data on this, that it reduces inflammation, can help lower joint pain. And I think of it as a wonderful replacement for drugs that are most commonly used, like the NSAIDs, like ibuprofen. And in elderly women, meloxicam, brand name Mobic, is given out like water by most orthopedists. And that's really bad because it increases the risk of heart attacks, strokes, kidney disease, kidney damage, and gut problems, including potentially fatal bleeds from the GI tract. This is hardly something that elderly women who have osteoarthritis need to be on. So Boswellia is so safe, and almost everyone can tolerate it. I recommend taking it with food, so that's a very good way to take it. Another supplement that's really helpful is curcumin, absorbable curcumin. It's derived from turmeric. It's incredibly anti-inflammatory. So everything that's anti-inflammatory is going to reduce pain. And we're going to talk about some dietary things, like an anti-inflammatory diet is very beneficial for women suffering from joint pain. Now, omega-3 is actually beneficial. Omega-3 is very anti-inflammatory. And one of the products that is derived from omega-3 are called SPM, Specialized Pro-Resolving Mediators. Now, SPMs are not omega-3, but they're derivatives from omega-3, just as endocannabinoids, which I'm going to touch on, are derivatives of omega-6. And SPMs, they promote healing and resolution of inflammation, and very, very helpful for joint pain. So SPM, Specialized Pro-Resolving Mediators, are great. And I mentioned endocannabinoids. So what about CBD? Notice I'm not saying cannabis. That I'm not talking about THC. I'm talking about CBD. So there are different products, and some of them contain other things like PEA that are very good for joint pain. They're very anti-inflammatory, and they're not hallucinogens. They don't affect cognition. So they're very, very helpful. So think CBD plus minus PEA, they're really good. Now, one of the newer ones that I really, really advocate for are products containing urolithin A. So urolithin A is a derivative of like pomegranates, and it's polyphenol, which is called ellagic acid. So urolithin A is a mitochondrial booster or enhancer, and there's amazing research showing that urolithin A, which by the way happens to be a phytoestrogen, as most of our herbal extracts actually turn out to be phytoestrogens, and urolithin A no exception. And urolithin A, because it boosts mitochondrial function, it actually creates more energy in a joint, and it actually can reduce inflammation, boost healing, and reduce pain in the joint. And it also is great for improving muscle healing and muscle function and muscle health. And of course, everything in the joint is ultimately connected to muscles. So that's really important. A lot of times when people have joint pain, they also end up with a lot of muscle spasms and muscle pain. So urolithin A is really, really helpful for that. A vitamin D, has been shown to be helpful for joint pain. The mineral magnesium, which has over 700 reactions in the body. So think magnesium as well. And collagen. So collagen can actually be helpful if you take a nice collagen supplement, and sometimes we call them collagen peptides. So there's a whole variety of ones on the market. Of course, I do encourage that. And then another one, which doesn't get talked about very much, it's a little bit pricey, urolithin A can be a bit pricey too, is SAMe. So SAMe, which is also known as the universal methyl donor, has been shown to be quite effective for osteoarthritis pain and osteoarthritis reduction in terms of the damage to the joint. So think also using SAMe. Another one of my favorites is an enzyme derived from pineapple, bromelain. It turns out that when you have damage to the joint and you have problems with the ligaments and you have problems with the cartilage in the joint and so on, that you have a lot of damaged tissue, okay? It turns out that if you take bromelain, which is a type of enzyme, and you take it between meals, it miraculously can help the body's immune system to actually sort of gobble up and get rid of some of the damaged tissue, which is actually involved in creating more inflammation and more pain. So these are some of my favorites. There are others, MSM, and that's another good one. So these are not, I'm not saying these are the only ones out there. These are my personal favorites. All have published data to support their use. So these are adjuncts to being on proper dosing and rhythms and regimens of hormone therapy. Now, I mentioned diet. Of course, diet is part of every therapeutic program. And an anti-inflammatory diet, one that's filled with lots of polyphenols and antioxidants and fiber to grow and nourish your gut microbiome, actually will help, will dramatically help sometimes. We have data that can show that going on a high vegetable, even a vegan diet, can lower the pain in joints by 50% in 1 month. How miraculous is that? So think plants of all kinds and less meat, but lots of protein from plant sources, and your joints will be so much happier. Now, one other supplement I didn't mention that I also like to use is hyaluronic acid. I mentioned hyaluronic acid. That's one of like the lubricants in a joint. And you can take oral hyaluronic acid, and that may help. Now, hyaluronic acid has also been injected into joints. But sadly, although it's still being used, the data doesn't show that it actually is very helpful if you inject it. What about other injectables? Well, PRP, platelet-rich plasma, may help, but you have to have estrogen, really, because you're trying to activate healing processes. You're trying to create growth factors, and you need estrogen on board. So I recommend for anyone who's getting, a woman who's getting PRP, that she be pre-treated if she's not on hormone therapy, to go on hormones, because you need to be able to create growth factors for healing. And that's what PRP, it's activated platelets, but they're not going to work in a desert. It's like trying to get the best seed and sticking it into the Sahara Desert. It's not going to grow. The same thing with things like stem cells, and they work. They work predominantly in young athletes who have an injury. They do not work very well in older people, like in menopause. They're not really old, but they're older because their hormones are gone. So if you're 50 plus, your ability to have benefit from stem cells and PRP is reduced. I'm not saying it's zero, but it is reduced because you're injecting into a non-healthy environment. And when you have stem cells, you're trying to grow. You need growth factors. What creates growth factors for healing and resolution of pain and inflammation? It's estrogen. So you need to have a proper environment for these injectables to actually show significant probability of benefiting you. In a young person, it's very different when they have an injury and they have these injectables, but not in people, women 50 plus. So osteoarthritis is not and does not have to be inevitable. Frozen shoulder doesn't have to be inevitable. And life has changed when you can't move your shoulder and it's in pain. It could take 2 years for that to be resolved. And that takes a lot of work and effort and pain to get a frozen shoulder to come back to reasonably normal function. So we want to be proactive with giving hormones during the perimenopause. We want to have the best anti-inflammatory diet, and then we want to use these targeted supplements, and we can try one or the other. We have a whole variety to choose from and see what works in each person, because everyone's a unique individual, so that we can prevent and resolve as best we can. Prevention is best, but if it's past that point and you already have this problem, then we want to get on hormones and we want to use all our tools in our therapeutic toolbox to try to improve joint health for better quality of life.